Hi, everyone. Thank you for joining us. Give us a few minutes and we're going to get started. All right, you guys. Well, thank you again for joining us for Cardiac Part 3. I hope you had a chance to join us for Cardiacs Part 1 and 2 earlier in the week and last week. Today, we're going to talk about common disorders of the cardiovascular system. Please feel free to put your questions in the chat box as we're going through. This is going to be an open discussion. I'll put in some questions as we're going through the lecture today so that you guys can follow and ask questions as they come up. So let's get started. So the first one I want to start off with is metabolic syndrome. It's a pretty straightforward one and one that you're going to see a lot in the clinic. Basically, metabolic syndrome is what they've classified a group of conditions as that puts the patient at increased risk for chronic comorbid conditions that cause end-stage organ damage. So this is a condition that increases their risk for heart disease, stroke, diabetes. And so you really want to watch the patient's blood pressure, high blood sugar levels, and obesity and their cholesterol levels. You're going to see this a lot in your clinic. And the primary thing to take away from metabolic syndrome is prevention. So prevention, prevention, prevention. You're going to talk to your patients about their risk factors. Do they have a family history of these conditions, blood pressure, diabetes, obesity? Are they themselves obese? Is their cholesterol high? Do you need to talk to them about their lifestyle? So physical inactivity, poor diet, and the primary driver of metabolic syndrome is thought to be insulin resistant. So we really want to talk to them about their lifestyle and their weight loss efforts. The prevalence is increasing rapidly. So in the US, you'll notice this number, adult patients, 41% are obese. So if you think about that, that's going to be half your patients coming into the clinic. They're going to be categorized in that obesity category. So you really want to screen your patients and make sure you're talking to them about their lifestyle and helping them with their modification. The other thing I wanted to highlight in this slide is the children. You see 17%, and that's going up too. So in primary care, we definitely want to look at our kids too and see, are they also in that obese category, and talk to them and their parents about what they're doing. Are they mostly sedentary? Are they getting out and doing physical activity, or is there a lot of screen time happening? What does their diet look like? And helping not only the kids, but the families as a whole talk about what they're doing, what they're eating to make sure that they're preventing some of these diseases moving forward. So prevention, prevention, prevention is the key to metabolic syndrome. The other takeaway I wanted to point out is that it's equal across the board between males and females. So you're really going to see this across the board in your patients. So the diagnosis, really, if they meet any 3 out of 5 of these criteria, you could diagnose them as metabolic syndrome. I think it's really just a new term to put out there so that both healthcare providers and patients can be aware of risk factor. So if they have a large waist circumference, if you're seeing slight elevation in their fasting glucose on their metabolic panel, if they're seeing some high triglycerides, again, talking to them about their diet and making sure they understand what is fatty liver and how to prevent it. Are they getting enough exercise, or is their HDL really low, below the normal limits? Are they always someone who's kind of a little hypertensive in the clinic? You see their trends and they're always kind of on that borderline. Talking to them about their weight loss efforts and making sure you're treating the underlying conditions is going to be really important. The other things I wanted to highlight about this slide is when you're getting your routine labs, yes, we want to do the metabolic panel and the lipid panel. Those are pretty straightforward. I always like to throw in a thyroid just to make sure we're not missing hypothyroidism, because oftentimes you're going to see some elevation in that lipid panel, and it's really untreated thyroid disorder. So you want to make sure that they're not obese or having difficulty losing weight because of an underactive thyroid condition. And same with their A1C. I think throwing in an A1C, if their insurance will cover it at least once a year just to get the average of their blood sugar, can be really helpful to look at the overall picture. Oftentimes, if you have patients doing a metabolic panel, if they haven't been fasting, you're going to see some elevation. If they have been fasting and you still see an elevation in their fasting glucose, you might want to repeat that and make sure that they come in definitely fasting. And if it continues to be high, you could do some other tests, but that A1C is going to give you that average across the last 3 months, so you can see if they're in that pre-diabetic range. The other thing I wanted to point out is looking at sleep studies. So a lot of times obesity and sleep apnea go hand in hand. So asking those history questions and making sure you're treating sleep apnea is going to go a long way with helping them with their weight loss efforts. So are they snoring at night? Do they wake up feeling tired, not rested? Do they feel like there's disruption in their sleep throughout the night? Some people might wake up with a headache in the morning, but definitely want to send them for that sleep study to see, is there some underlying sleep apnea that we need to treat? And we'll talk a little bit about this ASCVD risk score as well as we get into that coronary artery disease. So main takeaway, management, prevention, right, with metabolic syndrome. So lifestyle modification, looking at their diet, exercise, weight loss efforts. I don't want you to lecture your patients. I don't want you to make them feel bad, but meet them where they're at and try to help them. So say, I'm seeing these markers. These are putting you at increased risk for developing heart failure down the line, or coronary artery disease, diabetes. I'm really worried about you. What are your weight loss goals for this year, and how can I help you meet those weight loss goals? So having a conversation with your patient and really working with them, co-managing their conditions with them and including them in their management is going to go a long way with motivation and helping motivate your patients to make a change. And then managing their comorbid conditions. So don't ignore that hypertension, right? It's easy to just say, oh, every time they come in, they have white coat syndrome. Make sure when they go home, they're doing some blood pressure checks. And if their blood pressure is high at home too, then we need to have a conversation. Is this something that's been ongoing for a long time and we need to start medical management? Or is this something where if we have the motivation to address the diet and exercise piece, we're going to see that improve? So same thing with hyperlipidemia, having a conversation. If that patient is at increased risk with family history, then maybe it's something where early intervention is going to be helpful. But if it's something where, I could change my diet and exercise and lifestyle habits, let's give it another 3 months and see where we're at, retest those labs, then having that conversation with your patient is really important. The main driver for metabolic syndrome seems to be insulin resistance. So don't be afraid to use metformin for those pre-diabetic patients. I've heard providers have a lot of different point of view about metformin, and I really like it. Patients seem to be hesitant with metformin because it is labeled as a diabetic drug, but then they seem to not be so hesitant with the GLP-1s, which is also a diabetic drug. And what I like to tell patients is metformin side effect profile is so much lower and safer. Yes, you do have the nausea and the GI side effects, but those typically go away after a while. Your body adjusts and go low and slow with the dosing. So even if they have to be on 500 milligrams once a day for 3, 6 months until the body acclimates, I think metformin is a really good medication because it's safe and it really helps on that cellular level with that insulin resistance. So they're going to get most benefit from that metformin. Now, I did want to highlight the GLP-1s because you're going to see this a lot. It's really trending in social media. You're also probably going to have patients coming in asking you, can you write for a GLP-1? Wegovy, Saxenda, Zepbound. I really want to lose weight. I think there is a place for GLP-1s in weight loss management, but what I want you to focus on, again, is those lifestyle modifications. So if patients are doing the diet and the exercise piece and they need something to help with that hyperphagia, then a GLP-1 is a really good option. But if they're looking for an easy out, I want you to counsel them on the side effects of GLP-1 and make sure they understand that the research that we're seeing now is that patients who lose weight rapidly are losing more muscle mass than fat. So when they go off those GLP-1s, they're worse off than when they started them. So making sure that if they are starting a GLP-1, they're also committed to making those lifestyle modifications. That's going to be really important and beneficial for them in the long run. So making sure that they understand the risk factors and they understand the commitment that they're making with the GLP-1. And don't be afraid to slowly, as you're slowly titrating up, they reach their weight loss goal, also slowly titrate down. There's no real reason to do that other than for mental support for those patients because they've now lost all that weight and they're worried they're going to gain it back. So help them gradually come off those GLP-1s and see how they do on those lower doses until they go off those medications. So before we move forward, I want you guys to put in the chat, what is the key takeaway from metabolic syndrome? So what do you think is the key takeaway today? What is your role in primary care with metabolic syndrome? Go ahead and put it in the chat. Okay. So if you answered prevention, 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 you're absolutely right. So the key takeaway with metabolic syndrome is prevention. I want you to help educate your patients in understanding why we're screening for metabolic syndrome and help prevent things like diabetes, heart failure, heart disease, coronary artery disease, stroke. So prevention is the key takeaway. So now let's talk about some of those heart diseases we're trying to prevent. We're going to start with coronary artery disease. So as you all remember by now, your coronary arteries provide the main blood supply to your heart, right? So the coronary artery disease is when there's plaque formation in those arteries and it's preventing that blood supply to the heart. It's the most common form of cardiovascular disease in the US. It's the leading cause of death in the US and it's the third leading cause worldwide. So basically what that statistic tells us is that it's really common and our role in primary care, again, is prevention, right? So educating our patients about what coronary artery disease is and how can we prevent it. So a little pathophysiology with coronary artery disease. So again, your coronary arteries supply the blood, supply the heart with the blood that it needs for those myocardial cells to function. So when that plaque forms in those arteries, there's cellular changes. It causes more increased inflammation, enlargement of that plaque, and over time, that fibrous capsule develops. And what's dangerous about that fibrous capsule is that it can tear or bleed, which can then produce a thrombus. So you could have either complete or partial occlusion of those arteries, and then what it can result in is acute ischemia or eventually infarct or necrosis of that myocardial tissue. So that's what we're trying to really prevent. You might have patients who are asymptomatic who do have coronary artery disease. That's the most common. So coronary artery disease is usually asymptomatic until it's advanced. Then the patient becomes symptomatic. So they're going to come in most acutely with chest pain. That's a different topic for a different day. But if they're becoming symptomatic, saying, oh, I feel a little bit more short of breath, my exercise tolerance isn't there, I can't really run without getting winded as much anymore, they're becoming more symptomatic, you're going to see more advanced coronary artery disease in those patients. So they could either be asymptomatic or symptomatic. So if a patient is asymptomatic, don't ignore it. You definitely want to still get those screening labs, look at their lipid panel, look at their blood sugars, their blood pressure. But if they're becoming symptomatic, then most likely than not, they do have advanced coronary artery disease that needs to be treated. So risk factors, it is highest in males throughout the lifespan up until the age of 70. It equalizes with females. Females also are at higher risk once they reach menopause, but I don't want that statistic to make you think, oh, I just need to look at this for my male patients. I don't want you to ignore your female patients and say, oh, you're not really at risk for coronary artery disease. Please, please, please look at the whole picture and still look at our females and if they're symptomatic or not symptomatic, look at their family history. So yes, age does factor in, gender does factor in, but look at the whole picture, look at their lifestyle. Smoking is the biggest risk factor for developing plaque in your arteries, and we'll talk a little bit more about that with peripheral artery disease as well, but similar to coronary arteries and peripheral arteries, smoking is the biggest risk factor for developing that plaque. So definitely want to talk to your patients about smoking cessation. Sedentary lifestyle that we talked about. So again, diet, exercise, get them moving, get them outdoors, get them physically active, whatever drives them, whatever's going to motivate them, help them identify that and get them moving. Look at their other risk factors, so other comorbidities. We talked about metabolic syndrome. Are they hypertensive? Do they have diabetes? Do they have high cholesterol? Are they obese? So looking at the whole picture. The other thing I wanted to highlight is another risk factor is autoimmune or inflammatory disorders. So you might have a younger patient who's coming in complaining of exercise fatigue or exercise intolerance. And if they do have an autoimmune condition, whether it's been diagnosed or not diagnosed, you want to be thinking about that in the back of their mind because it is an inflammatory condition that does increase their risk for having coronary artery disease. So have that in the back of your mind. A way to screen these patients, I really like the ASCVD 10-year risk score. It factors in whether they have diabetes, if they have hypertension, if they're being treated. It also gives you recommendations on the intensity of the statin, which I really like, that I find useful in clinic. The downside with the 10-year risk score is that it is used for ages 40 to 75, so it's a little bit limiting, especially in that if you have a patient in that 30 to 40-year-old window, it can be a little bit limiting. But you want to screen, and you want to screen early, especially in patients with a family history. Oftentimes, early intervention in those patients can help improve outcomes. So definitely want to screen family history, ask those questions. And if it's a symptomatic patient, then we want to make sure we get further testing done, get an EKG. You might want to do a stress test. Maybe they need to see cardiology for a consult. If they have significant family history, they're symptomatic, and they have some of those other comorbidities, then they probably need to see cardiology just to see if there's further testing that needs to be done to evaluate the degree of coronary artery disease. So management, we talked about non-pharmacologic, so definitely lifestyle. We talked about the diet, physical activity, weight loss, smoking cessation. Again, I really want to drive that home. Don't ignore it with your patients. Try to touch on it each visit if they're still smoking. Pharmacologic management, so getting them on statin if the guidelines are recommending it, and also treating the other comorbid conditions, so hypertension, diabetes, and if it's further advancing, you're probably co-managing these patients with cardiology. Congestive or chronic heart failure, CHF, they're both one and the same. There's lately been a trend to try to move to calling it chronic heart failure, but CHF, congestive heart failure, chronic heart failure, they're one and the same. Majority of the cases of CHF are secondary to coronary artery disease and the MI. So you're going to also see this in your patients, most likely in your older patients once they've had if they've had coronary artery disease for a long time, or as they age, they're at more increased increased risk for developing more symptomatic CHF. So it's the highest cause of hospitalization in your elderly. I did also want to point out that you're going to see it in patients probably with structural heart disease as well, or valvular disorders. So that's going to be another common reason for heart failure. And then also any conditions that put increased demand on your patients. So you might see it in your pregnant patients. That patient definitely needs to be managed by cardiology, or if they've had chronic anemia that's been untreated, that puts a lot of strain on the heart. So they could be developing CHF from that as well. So right-sided heart failure, we probably all know this by now, but just a quick review. The right side of the heart can't move the blood through the lungs, so it backs up to the body. You might see the JVD on exam. You're going to see that they have ascites, a lot of fluid in their belly and the abdomen. They have the dependent edema. They might feel more fatigued or not as hungry often because they have all that ascites or fluid on board. Left-sided heart failure, the blood flow is not moving out of the heart, so it's backing up into the lungs. So you're going to have patients that probably are complaining of shortness of breath, cough, asking them questions about, do they lay flat at night, or do they have to elevate their pillows at night? These patients oftentimes, if it's really advanced heart failure, have to sleep in a recliner all night. So really asking those questions to figure out what is their lifestyle and what are the limitations on their lifestyle because of their chronic condition, right? And then when you listen to their lung sounds, you're probably going to hear those crackles and those basses, but it's all backing up in the lungs with the left side heart failure. With CHF, you want to classify it with the New York Heart Association functional classification system. So there are 4 classes of heart failure. What you'll notice between the classes is really limitation or not limitation in their physical activity, right? So that's what makes the difference between the classes. So between 2 and 3 is there's slight limitation. They're comfortable at rest. They can do their normal activity. And then with 3, they're starting to get more limited, right? They're starting to feel more fatigued with their normal activity, and it's starting to limit their daily activity. So looking at quality of life with these patients is really important. And for diagnostics for these patients in the office, you can do an EKG, run your routine labs, look at their electrolytes, make sure they're not off, look at their kidney function. If you think something acute is going on, you can do a chest x-ray, make sure they haven't developed some secondary infection from all the fluid backing up in their lungs. But you're also, I think the primary diagnostic for these patients is the echocardiogram. So again, you're going to be co-managing these patients with cardiology because they're going to be routinely getting echocardiograms on these patients just to make sure that it's not advancing. So again, our role in primary care for this patient population for CHF is screening, identifying, and preventing, right? So we want to make sure we're monitoring the patient's weight, we're monitoring their blood pressure, we're screening for diabetes, and we're addressing all of these things. Do they have a strong family history? There are some prediction calculators. I don't personally use them, but I think you could find, if you find it useful, you could use it in the clinic. But the idea is we really want to help manage some of these comorbid conditions so that we're preventing it from leading to this heart disease, right? Leading to CHF. So prevention is key. Talking to them about exercise, making sure even patients with CHF are getting out and they're moving and they're walking. Working with them on their weight and their diet, controlling their blood pressure, controlling their blood sugars. And again, that smoking cessation pops up, right? We're going to talk about the use of SGLT2s. They have recently been approved. It's a diabetes medication that's recently been approved for heart failure. The jury's still out. Some providers like it. Some providers wait for cardiology to start it. So as you get more comfortable, you'll probably see patients more and more on these types of medication. But in primary care, our goal is to really help the patient understand their disease process and what they could be doing to prevent hospitalization, right? So prevent the acute exacerbation of CHF. So if they're getting that peripheral edema, you want to talk to them about compression stockings, making sure they're keeping their legs elevated. They want to monitor their daily weight. So why is that important? You also want to educate your medical assistants on this so they don't want to just copy and paste from the last visit their weight, you want to get that patient on the scale and see what is their weight. They should be also weighing themselves first thing in the morning after emptying their bladder. What is their weight? Because that helps us determine, are they getting a lot of fluid backing up where it shouldn't be, and do they need to be adjusting their diuretics? Restricting their fluid and their sodium intake, and then getting them to cardiac rehab. So remember those classifications we talked about, physical activity. Cardiac rehab is a really good way to get these patients moving, making sure that their quality of life is still preserved, that they're not just sitting at home getting worse and worse and worse and declining. And some of these patients may be on oxygen if they're in class 4 or later, and their disease is very advanced. So most often than not, in the outpatient clinic, you're going to be managing the patient with diuretics, and you're going to be co-managing these patients with cardiology, and they're probably going to have them on ACE inhibitors, beta blockers, vasodilators. You're mostly going to be managing the diuretics. Once you get a little bit more comfortable, you might be more comfortable adjusting some of their other medications, but you're going to see that they're going to be on a slew of these types of medications. And in pediatric patients, they always want to be managed by cardiology. Okay, so first question, go ahead and put answers in the chat for me. But patient with cardiovascular disease requires many medications to prevent further complications. So remember prevention, right? In patients with coronary artery disease who also have heart failure, which of the following classes of medications should be prescribed for secondary prevention? You can select all that apply. So ACE inhibitors or ARBs, beta blockers, calcium channel blockers, or aldosterone antagonists. Go ahead, put your answer in the chat for me. Okay, so if you answered A, B, and D, you are correct. So remember, ACE and ARBs are going to help lower that blood pressure and reduce the afterload on the heart. Beta blockers are going to lower the blood pressure, rate control the patient, and it also has been shown to reduce the risk of death in patients with a reduced ejection fraction. And spironolactones also used as adjunct therapy. So it is a diuretic. It helps with that, and also helps reduce the risk of post-MI patients with heart failure. So absolutely correct. Good job, you guys. So now we're going to talk about peripheral vascular disease. And with that, it's a big, wide category. Today, we're going to focus on the highlights, what you're really going to see in the clinic, and how you're going to diagnose and manage it. And we're going to start with peripheral artery disease. So remember, just like we talked about with coronary artery disease, these are your arteries, right? So it's the blood supply to the rest of your body. So it's a circulation condition where narrowing of the blood vessels causes the reduced blood flow to those limbs. So you're developing plaque and fatty deposits and calcium buildup in the walls of the arteries in the rest of your body. So just like in the coronary arteries, also the arteries in your peripheral vasculature. Hallmark sign is the claudication. So you're going to have patients coming in saying, you know, I've been going for walks and I get cramping in my lower legs, and I'm not quite sure why, but then it goes away when I rest. What is that? So if you hear the patient saying they're getting cramping or that claudication in their lower extremities that goes away with rest, that should make you think PAD. So this is likely peripheral artery disease. Risk factors, again, age and gender. So oftentimes you're going to see it in that older male patient. They might be obese. They might not be as active as they should be. So sedentary lifestyle. They have other chronic conditions that increase that inflammation in their body and cause that plaque buildup. So they're hypertensive, they're diabetics. Smoking, again, I really want to highlight smoking. So smoking is the biggest risk factor for developing all that plaque in your arteries. But basically, the telltale hallmark sign for PAD is it should be reproducible and relieves with rest. So think PAD if you're seeing that patient in the clinic. So how do you diagnose it? How do you make sure that this is PAD? You can send them for an ABI. Typically, an ABI is done within a cardiology practice, so you'll send them over. They will measure both the systolic pressure in their arms, their ankles to see if it's normal and if it's the same. In a healthy patient without peripheral artery disease, it's going to be the same. There should be no difference in the arm and ankle pressures at rest or exercise. But in a patient with peripheral artery disease, there'll be significant decrease in that distal pressure in the affected limbs, both at rest and during exercise, right? So you're getting that narrowing of those arteries because of all that plaque buildup. So the pressure is going to be reduced back there, right? You want to educate your patients before you're sending them. Hopefully, wherever you're referring them to, we'll also call them and prep them a little bit for the ABI, but let them know if they are smokers, don't smoke 30 minutes before the test and no exercise 30 minutes before the test because you want to make sure that the results are accurate. And if this comes back abnormal, then again, referring to cardiology to look at the extent of the peripheral artery disease is going to be really important. So our goal in primary care, what are we going to do for management? So we're going to help them with their functional capacity and make sure that, again, prevention from having it get worse. So talking to them about lifestyle management, heart healthy diet, exercise, smoking cessation, again, really important. We want to help reduce the amount of wounds that they're getting because they're not getting the blood flowing where it needs to go. And we want to reduce that ischemia to their vessels, right? These patients are most likely going to be on antiplatelets, probably on statins as well. And oftentimes, if it's really advanced, then they're probably going to need to see a vascular surgeon just to see if there's any further intervention, if they need to clean out those arteries, which is a much more in-depth procedure. So chronic venous insufficiency. So we talked about peripheral artery disease, right? So the blood flowing out. Now we're talking about venous insufficiency. So the blood coming back to the heart. So in this, the pathophysiology, just so you remember, is it's improper function of the vein valves in the leg. So it's causing swelling and skin changes because the blood is not flowing back up to the lungs and the heart. It's actually staying in those lower extremities. So you're going to see the blood vessels getting a little bit more loose. You're going to see a lot more edema in those lower legs, varicose veins. Again, risk factors. Age, it has a lot to do with it. Sedentary lifestyle, if they're more obese, smoking again, you're going to see it in your pregnant patients. So talking to them about wearing compression stockings. If you have a patient who's on their feet all the time for work, you're probably going to see it there too. So they're going to see a lot more of the venous insufficiency. So history questions are really important. So most cases of venous insufficiency occur in the superficial venous system and manifest as varicose veins. So that's going to be the most common thing you'll see in the clinic. You might see swelling again, skin color changes, a red flag. So it can progress to leg ulcers. So making sure you're preventing ulcers and you're also, if you do see wounds, you culture it and then make sure you send them to wound care and those wounds get resolved is going to be really important because you don't want those wounds to go untreated. So talking to your patients about checking their skin daily, also skin care is just going to be really important. And again, if you are suspecting this, then you do need to send them to cardiology to do an ultrasound, do a Doppler, do a venous Doppler, and make sure what is the extent of the venous insufficiency and does it warrant further intervention? So do they need to see a vascular specialist? That's going to be really important. So in our role in primary care, again, helping those patients understand what's the benefit of wearing compression stockings, elevating the foot of the bed, getting them to move and be active. That's going to help those muscles move the blood flow back to the lungs and the heart. So avoiding prolonged inactivity or just sitting or standing for a long time. Changing positions often is going to be really important, and checking for wounds and making sure skin care is addressed in your visit is going to be really important as well. And again, if it's getting really bad, get wound care involved, and then also a vascular specialist if they're looking for other treatment options, surgical treatment options. Superficial and deep vein thrombosis. So SVT, it's a clot that occurs in the superficial vein. So oftentimes you're going to see this with redness and and pain in the affected site. DVT, or deep vein thrombosis, that's the formation of the clot in the deep vein. So that's the one we really worry about. 43% of these turn into pulmonary embolism. So you definitely want to screen for DVTs if you're suspecting it. For SVT, oftentimes you'll see these patients if they have IV therapy, trauma, infection. Those are going to be the most common causes. For DVT, you are definitely going to see this more if they've patients had recent surgery. So ortho being the highest risk for DVT, orthopedic surgeries. If they've been recently hospitalized, again, if there's trauma to the area, or if they have other underlying comorbid conditions like clotting disorders or cancer, that's going to put them at more increased risk for DVT. Our female patients, if they're using estrogen for birth control, you want to also screen them. If they're smokers, obesity also is a risk factor. I remember I had a patient, 31-year-old, who came to my office, very obese. He was complaining of shortness of breath. He was having a hard time walking uphill. So it wasn't obvious shortness of breath, but he felt like it was taking him more effort. Upon further interview, asking my history questions, I realized he had just flown to another state, long flight, had surgery. So he had a gastric sleeve done, and then he had just come home and these symptoms had presented after recent surgery, a long flight, and he was obese. So he's kind of hitting all those risk factors there. Sure enough, the Doppler showed multiple DVTs in his lower legs. I also got a helical CT on him, and he had a large central PE. But in the office, everything looked and sounded normal. So oftentimes, if they're young, you're not going to really see much on the physical exam. But the well score is a really nice way to screen for DVT, and you can also put it in your charting, just so you can be reassured, is there a low probability or high probability for a DVT, and it helps you determine your next steps. So that well score will go through your risks and give a little number to it, and then at the end it'll tell you if it's a low probability or high probability of DVT. But on physical exam, you might see calf swelling, so you want to definitely measure, is there more than 3 centimeters swelling greater in one leg versus the other? Is there pitting edema? Is there swelling of the entire leg? So that's not normal, right? Is there localized tenderness of that deep vein? Are they short of breath? This 30-year-old patient, he had none of that. His lungs were clear, and all he really felt was he just did not have the lung capacity that he did prior to his surgery and before coming back. So I had a high suspicion. I did an EKG in the office and saw inverted T waves, sent him over for the Doppler as well as a helical CT. Sure enough, large central PE, multiple DVTs, got him on the proper treatment. But definitely want to use that well score in your charting to help justify whether you're going to continue with further testing or if it's a low probability. So for that patient, what was the treatment? So oral anticoagulants. I think I started him on Xarelto. This was a couple of years ago now, but you can start him on Xarelto, Eliquis, Pradaxa. Those are all first line. Warfarin is not really in favor anymore, but again, it depends on the provider. So if your office likes warfarin better, if you guys have a warfarin clinic, you might want to start the patient on warfarin, but it does require more frequent monitoring of that PT-INR, and you do have to, it does have a lot of drug interactions, so you have to stop therapy before surgery or make sure that they're not on any other drugs that would interact with the warfarin. But the benefit of warfarin is that the bleeding risk is a little bit lower, so you can take that patient off the warfarin, which with the Xarelto and the Eliquis, some patients worry about that bleeding risk. But in this patient, again, you're going to be co-managing them with cardiology, and they're most likely going to be on treatment for about 3 to 6 months. Non-pharmacologic therapy, so in that SVT or that superficial, the superficial thrombosis. So in our pregnant patients, we talked about compression stockings. You can also try NSAIDs or talk to them about topical heparin gel. But again, it's mostly you don't want to miss that DVT or PE. So practice question, which of the following risk factors for peripheral artery disease is most likely to result in arterial calcification? So go ahead and put your answers in the chat there. So what have we been talking about? So what's going to put you at most increased risk for developing that plaque in your arteries, in your coronary arteries, in your peripheral arteries? What's going to put you at risk? Awesome. You guys have been listening. That's great. So peripheral artery disease, it's we talked about the plaque building up again in those peripheral arteries, and smoking is definitely one of the biggest risk factors in your patient. So smoking results in the highest amount of direct inflammation leading to arterial calcification. So please don't ignore smoking cessation in your patients. If they're still actively smoking, you want to talk to them about that. All right, my friends. So now I'm going to open it up to a Q&A. If you have any questions on what we talked about today, please go ahead and put it in the chat and we'll address it. I also wanted to tell you guys a little bit about our website. Make sure you guys check out our Q Bank. So we have over 1,400 questions in our Q Bank. I think we're almost up to 1,500. We also have these videos coming on demand soon and a 3-day live review coming at the end of May, beginning of June. So go ahead and register for that. Registration is already open. If you go ahead and scan this QR code, you can register for all our webinars coming up and follow us on social media so you don't miss out. We've got a lot of great stuff for you coming up in April, and both this week, next week, we've got some more reviews. So please check that out. And as always, we're here for you for your boards and entering into clinical practice. So if you have any questions, go ahead and email us, and we'd love to have you reach out. All right, you guys. Oh, we've got a question here from the group. What blood thinner is best? So go ahead, and I want everybody to answer. Put in your best answer. What do you think? What blood thinner is best? So again, it depends on what we're talking about, right? So if we're talking about that large central PE, we're definitely going to start them on something like Xarelto or Eliquis. So it depends case by case basis. So you have, different options, and you want to make sure you're looking at the patient and what's going to be best for them. But if we're looking at for DVT and PE, first line is going to be those oral anticoagulants. Good question. So the live review, that's a really good question. So we're going to have 2 full days on Friday and Saturday. I think it's between 8 to 4, 8 to 5, and then on Sunday, half day. So the live review is going to be all day on Friday and all day on Saturday, and then half day just in the morning on Sunday. And it's going to be all encompassing. So we definitely want you guys to check it out. It's going to go over everything you need to know for your boards. So somebody asked, I signed up for the 3-day live review. Are we going to have handouts for the review? And that is a big yes. There are going to be handouts so you can take notes and make sure you understand everything you need to know going into your boards. And you have 30 days to rewatch the videos if you'd like. So the live review comes with access to handouts as well as 30 days access to rewatching all those videos from the 3 days. Great question. So we have a question, I think, from social media. If we can clarify it, what the question is, if we're talking about PEA, pulseless electrical activity, or if we're talking about PDA, go ahead and clarify that question for me. Okay, so the question was for, yes, pulseless electrical activity. So we didn't get a chance to go over arrhythmias today. We can do a separate lecture on that when we have more time. We'll definitely cover it in our 3-day live review. But today we focused on mostly chronic conditions, the cardiac chronic conditions. All right, you guys, great questions today. Thank you again for joining us for our part 3 of cardiac review. If you have any further questions, feel free to email us directly. Again, we are here for you for your boards and also for entering into clinical practice. You guys are going to do great. Hopefully, we'll see you next week on our webinars and also for our 3-day live review at the end of May. Thank you again and have a great day.